Hello, everyone. Hi, welcome to the Academy for Eating Disorders webinar entitled Gender Identity in Eating Disorders, Medical and Psychological Considerations with Dr. Carly Gus and Dr. Amy Tishelman. My name is Dr. Melissa Freisinger and I am your moderator today. Also with us is Ronald Fan, AED's membership manager. If you have any questions or concerns about this webinar, please feel free to reach out to Dawn Gannon at AED headquarters via email at dgannon, that's Gannon, at aedweb.org. Okay, so just a few housekeeping items before we get started. All participants are muted with the exception of the speakers and myself. The webinar is scheduled for 60 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Gus and Dr. Tishelman will begin their presentation, after which they will answer questions from the audience. Please feel free to submit your questions to the speakers during the presentation using the Q&A text box on the bottom middle of your screen, and I will read them to the speakers when the question portion of the webinar begins. Okay, so let's begin by introducing our speakers. Dr. Carly Gus is an instructor in pediatrics at Harvard Medical School and in the Division of Adolescent Young Adult Medicine and the Division of Endocrinology at Boston Children's Hospital. She is the co-medical director of the Boston HIV Adolescent Provider and Peer Education Network for Services. Happens is the name of the program at Boston Children's Hospital. Her research interests include transgender and gender nonconforming adolescents' experiences in primary care, the relationship of gender identity to body image, and pre-exposure prophylaxis in adolescents. Carly received her BA in History from Yale University, her Master's in Public Health from the Harvard T.H. Chan School of Public Health, and her medical degree from the University of Michigan. She completed her residency in pediatrics at Hasbro Hospital in Providence, Rhode Island, and fellowship in adolescent medicine at Boston Children's Hospital. Dr. Amy Tishelman is a clinical and pediatric psychologist. She is a senior attending psychologist at Boston Children's Hospital and an assistant professor at Harvard Medical School. Dr. Tishelman is also the director of clinical research for the Gender Multi-Specialty Service, named GEMS, and the Behavioral Health, Endocrinology, and Urology program at Boston Children's Hospital. GEMS provides clinical care for children, adolescents, and young adults identifying as transgender, gender diverse, while its BE-U program serves youth with a spectrum of conditions classified as intersex and/or differences of sex development. Dr. Tishelman currently is an MPI on an NIH grant studying gender development in prepubescent children and a co-investigator on another NIH grant studying mental health and medical outcomes in transgender adolescents. She recently completed work as an MPI on an NIH-funded study of psychosocial outcomes in youth and young adults with DSD diagnoses. Dr. Tishelman currently chairs a committee developing new international standards of care for gender diverse children for the World Association of Transgender Health, and co-chairs an American Psychological Association task force on differences of sex development. She also has expertise in child abuse and trauma. Dr. Tishelman speaks and publishes frequently in her areas of expertise. My name is Dr. Melissa Freisinger, and I am an attending psychologist in the Department of Psychiatry and adolescent, did I say psychologist? Psychologist in adolescent medicine at Boston Children's Hospital. I am also the Associate Director of the Eating Disorder Program in Adolescent Medicine and Young Adults at Boston Children's Hospital, and I'm an instructor in psychiatry at Harvard Medical School. So thank you, Dr. Gus and Dr. Tishelman. We will begin the presentation now.
Okay. Hi, this is Amy Tishelman. I'm very happy to be here today, and I appreciate being invited. I'm going to give a brief overview about gender diversity and transgender youth before turning it over to Dr. Gus to talk more specifically about eating disorders in this population. None of the speakers today are members of the transgender community. So first I'm going to talk about terminology because I think it's important to understand what we're talking about. So very briefly, I'm going to talk about some key terms that we use. Gender identity is not observable. It's a person's internal, deeply felt sense of self, and it can be on a spectrum. It may or may not correspond to a person's designation at birth or the way they were initially raised. It may not, or it may correspond to a person's primary or secondary sex characteristics, meaning there can be a mismatch between external sex characteristics and internal sense of gender identity. And you can't know a person's gender identity by looking at them. It's not visible to others. You really need to ask them. An affirmed gender identity refers to a person's asserted gender identity. That means what gender they tell you they are. It's the gender by which one wishes to be known. Gender expression is not the same as gender identity. Gender expression is a presentation of an individual in the world. It refers to the way they present themselves with regard to clothing, hair, physical appearance, clothing choice, accessories, and behaviors that in a certain culture express aspects of gender identity and role. Transgender, the term transgender really is an umbrella term used to describe the full range of gender identities. Let me just see if I can move this. And it basically, a person who's transgender does not conform to what is typically associated with their sex assigned at birth. Again, it's not always visible, and it's something that you need to ask. Cisgender describes most people, but it's a person whose gender identity, gender expression align with the sex they were assigned at birth and the way they were initially raised. So it's a congruence between a designated sex and an experienced gender. Sex refers to a person's biological status. It's typically categorized as male, female, or intersex. And intersex is an atypical combination of features that usually distinguish male from female. Intersex is also sometimes labeled differences or disorders of sex development. So that's the program that I work in here at Children's Hospital also. Sexual orientation is separate from all of this, and it refers to the sex of those to whom one is sexually and romantically attracted, and it can vary independently of all the other factors related to gender. So gender affirmation is an interpersonal and shared process through which a person receives social recognition and support for their gender identity and expression. So when you accept a person who defines themselves as gender diverse or transgender, you are affirming their gender. And it can be social, accepting somebody's name and pronoun, medical, including being able to access and be prescribed hormones that are essential for affirming a gender identity, and legal, referring to legal aspects of gender identity, including gender markers on a license. So this is a depiction of the continuum of gender and sex that are possible. Each of the continuum that are depicted here are independent of one another, and so they all need to be queried separately. So in this particular depiction, gender identity can be on a continuum of female, male, female, woman, or girl, and that's separate from the continuum of male, man, or boy. So people can identify how much they are female, and separately how much they feel they are male, or an other gender that we don't typically recognize in historically. Gender expression also can be depicted on a continuum as female, and separately on a continuum of masculine, and separately on a continuum of other. And sex assigned at birth, I've mentioned already, can be female, male, or other intersex. Who somebody is physically attracted to and emotionally attracted to is separate from all this, and we recognize that people can be physically attracted to individuals separately from whom they are emotionally attracted to. So again, there are independent continua of women, men, other genders, and emotionally attracted to women, men, or other genders. And this recognizes that you can be physically attracted to both women and men and people who are gender diverse, and emotionally attracted to all three of those identities as well. So I'm just going to very briefly, because we don't have too much time, talk about gender development. And so I already mentioned social transition, or the expression one presents themselves in the world. That's what we mean by social transition. For younger children before puberty, the only really interventions to affirm somebody's gender identity are social, and there are no medical interventions. So social transition is a non-medical intervention for gender dysphoria or gender diverse children, whereby an individual adopts a preferred name, hairstyle, clothing, and or gender pronouns that are aligned with their affirmed gender or their gender identity, rather than their birth assigned sex. It's possible for people to affirm be typically expressing themselves as a male in some ways and a female in other ways, conforming to current social standards. A social transition is an expression of one's gender identity that is shared with others in the social context or social environment. And a person can be gender diverse or transgender but not socially transition, or they could partially socially transition in terms of some aspects of their presentation, or they can attempt to completely socially transition in every way that they can identify to be perceived in accordance with their gender identity. So a social transition in prepubescent children is controversial as an intervention. Some people feel very reluctant to approve of children socially transition before they're older and before they're adolescents, whereas others are more affirming of social transition in childhood. Some of the concerns about younger children socially transitioning are that research shows that gender identity can be in flux, and that some children who identify as gender diverse or transgender as before puberty don't continue to identify that way after puberty. And if we had more time, I would review that research in depth. There's research that shows a high number of children who actually do not maintain a gender diverse or transgender identity in the transition to adolescence. However, that research is methodologically flawed, and so we don't have good data on how many children do maintain a transgender identity from that proceeds intact from prepubescent children to adolescence. But there is some aspect of gender identity that's indeterminate. Sometimes children may transition because of the parents' discomfort. For instance, I've worked with families where the parents are really struggling with the ambiguity of not knowing their child's gender identity, or their child not choosing to be male or female, but considering it over time. So there can be pressure for a child to decide if they're male or female, and parents can be gatekeepers in that way. On the other hand, sometimes parents don't want their children to socially transition when the children want to. Some professionals worry that if a child socially transitioned, which is hard to do, and it involves sometimes working with schools and others in order to support a child's social transition, that children may feel boxed in, that they may feel embarrassed or ashamed to then go back to say, I think I made a mistake and I want to go back to living as the gender I was initially raised as. So there could be a feeling that once they decide to transition, they shouldn't undecide, and that can be difficult. And most of us recommend that if kids do socially transition, they be given the message that they get to decide if they want to stay that way or not, and that nobody would be upset if they decide that that wasn't the best decision for them at a different point in time. There may be greater risk of bullying and social ostracism for kids who transition and are identified as transgender, because their research does show there's a lot of social rejection in some cases for kids who are who are perceived of as transgender. There's also not a lot of research about whether if kids detransition or decide that they want to live in the gender that they were initially raised, that there may be negative mental health implications for detransitioning. There's also sometimes concerns that if kids transition as before adolescence and then they go on puberty blockers, which Dr. Gus is going to explain in a little while, which stalls their puberty and prevents them from going through the programmed physiological changes associated with their sex at birth. They do not experience gender associated with their assigned sex, and maybe if they did experience those changes, they would feel more comfortable in their assigned sex from birth. There's also concerns that kids who socially transition go on puberty blockers and are then given cross-sex hormones that are aligned with their gender identity, transgender gender identity. They may detransition, it may be premature, and they may end up detransitioning after irreversible medical interventions, which again, Dr. Gus will talk about in a few minutes. This is actually a very significant concern that people have, that's being raised often as a concern, that if kids are given medical interventions and then they detransition, they may have irreversible impacts of their medical interventions. And finally, some children, as depicted in the gender unicorn slide, don't identify necessarily as male or female. They may identify somewhere on a continuum with regard to both being male and female, and that's often called a non-binary gender identity. If you have a non-binary gender identity, there's not necessarily a gender presentation that's culturally accepted as non-binary, and it may not really fit easily into what we call social transition, because social transition often refers to living as a boy or as a girl. Non-binary presentations can be very variable. So some of the benefits of social transition, which I have clinically seen in children that I work with, are an improved quality of life in childhood. Some children who identify as gender diverse or transgender are really miserable being identified as what they feel is the wrong gender, and it can be depressed or acting out. So there can be an improved quality of life in childhood associated with a social transition and an affirmation of a child's gender. It can also be, we hypothesize that it can be psychologically protective, because there's a lot of psychological morbidity for adolescents who are transgender. And so we don't have enough data, but some research that's beginning to be conducted indicates that children who do socially transition and are affirmed in their gender identity are socially well-adjusted, or psychologically well-adjusted. So it can be psychologically protective, and we hope maybe children who are affirmed in their gender identity in childhood and never have to live and feel like they're living in the wrong gender will be able to evade some of the negative psychological morbidities we often see in adolescents. Family support is also linked to social transition. As I mentioned earlier, children who socially transition have parents who are gatekeepers, and truly parents have to make the decision that their children are going to socially transition or to allow that. And so that can be, social transition can be a proxy for parental support. And kids who socially transition may never have to feel an incongruence between the way they're perceived in their gender and the way they feel internally in their gender. So kids who socially transition, go on puberty blocks and then cross-sex hormones, can be spared the negative effects of an incongruence between their experience and their affirmed gender. So there is a little research that I'm going to whiz through because I'm going over time, showing that kids who have socially transitioned have positive psychosocial adjustment, and their psychological adjustment is similar to cisgender kids who are not transgender, and non-transgender siblings. For instance, kids who have socially transitioned had self-reported and parent-reported depression and self-worth that didn't differ from peer and sibling comparison groups. This research, headed up by Christy Olson, did show that there was elevated anxiety in this group, but the anxiety that was elevated wasn't in a clinically relevant range, meaning they're a little more anxious, but didn't meet criteria for anxiety disorder. So the conclusions we can draw from this research are that familial support can be associated with better mental health outcomes. And there's other research to indicate that as well, that social transition may be psychologically protective for some transgender youth, and that it's, most importantly to me, that it's not inevitable that youth who identify as transgender experience negative mental health consequences. And I think that's really, really important for families to feel a sense of hope, for kids to feel a sense of hope, and to realize that being transgender does not mean that you have mental health problems. It's separate. You can be a well-adjusted person who is transgender, and that's a very important message to understand. On the other hand, as I alluded to before, there are many adolescents and young adults who are transgender who do experience very significant mental health morbidities, which many people, including I, attribute probably to the minority stress and rejection experienced by transgender individuals. So there's about 3 times as high levels of depression, anxiety, suicidal ideation, and suicidal attempts in this population, which is very sad. Research shows suicidal ideation in adolescents at 40%, 50% levels, sometimes for adolescents who are transgender. And this is just one slide from one study headed up by Sari Reisner, but there are many studies showing this same morbidities. So to just go through this very quickly, there is research to show that puberty suppression and receiving gender-affirming cross-sex hormones does result in better psychosocial adjustment in transgender youth. And just to finish up, I want to say that it is important to ask your patients about their gender identity. I think it's just very reasonable to be very straightforward about it and ask the people that you're working with, what is your gender identity? And you can preface it by saying, I ask everybody this because gender identity is not visible and many people are affected by gender issues. So you can say, what's your gender identity, and if people seem confused, you can say, do you think of yourself as a boy, as a girl, or someone else? And also query about what pronouns people use. And again, you can just be very direct. What pronouns would you prefer me to use when I speak with you? And what name would you like me to call you? You can ask what others call them, because sometimes there is a difference between how people affirm their identity, what pronouns they prefer, and what pronouns other people use to refer to them. And you can also ask if there are any concerns in this area for your patients, and whether they also have concerns about sexuality or sexual orientation. You can ask them if they've been exploring issues of sexual orientation and gender as well. And I think these are very important questions to keep in mind when you're working with your patients. So thank you very much. I'm going to hand it over to Dr. Gus.
All right, thank you, Dr. Tischelman, for that great introduction and baseline definitions. So we're really trying to fit a lot in this brief webinar. We could spend days talking about gender affirming medical treatment, which unfortunately I'm not going to have the time to do here, but just to sort of visually show you, there's lots of great places in which one can learn more free, open source about the various options for medical transition. I personally like the UCSF Center of Excellence for Transgender Health and the Endocrine Society. The WPATH, that image in the middle, is, as Dr. Tischel mentioned, who's working on it, is in the works for a more updated version. And important to note that treatments are off-label. And as we heard a little bit about, there is a intervention option that we think of as being reversible to block or pause puberty. These medications are GnRH analogs, which inhibit the hypothalamic pituitary gonadal axis. In the clinic where we work in Boston, we often do an implant, the histrelin acetate subcutaneous implant, but can also be given as a shot every month or every 3 months to sort of pause puberty. And we really think of this as a reversible intervention. It's actually been around for decades for precocious or early puberty in cisgender girls. So if someone were to decide, I don't want to pause puberty, I want to go and continue in my sex assigned at birth puberty, they would discontinue treatment and puberty would progress. Since this is a talk that's really focused on taking care of patients with disordered eating or eating disorders, just to include from the Endocrine Society guidelines that there's not been found to, when folks are on these puberty blockers, to change BMI in transgender adolescents. However, there are changes in fat mass and decrease in lean body mass percentage, which is the same for cisgender girls with precocious puberty. So not a lot of surprise there. And that when we think about, I'm not sure if there are any dietitians who are tuned into this, kind of what other dietary counseling might we want to give. We know that puberty and sex steroids like estrogen, testosterone are really important for bone health. And so that we try to have young people optimize their bone health by taking calcium and vitamin D, engaging in weight-bearing exercise as appropriate for patients with eating disorders, determined by their treatment team, as we would for any person regardless of gender identity. So when we think about gender affirming hormones, even though we think of gender as being beyond the binary of just masculine or feminine, our treatment options are really binary for right now. So for masculinizing hormones, we think about testosterone. Again, lots of changes with testosterone, hair growth, voice deepening, etc. But when we think about taking care of patients with disordered eating and eating disorders, what might you specifically want to know if patients are on this treatment? So they're going to have increased lean mass, increased body weight, increased strength, and amenorrhea or lack of periods. This can be desired by those on the masculine spectrum, so people who identify as male or on that spread, or non-binary, so neither female or male or genderqueer, again, neither or potentially fluid, etc. And that will become important later, right, when we think about kind of how we think about recovery and things like that in folks who have a uterus in eating disorder care. Then we also have feminizing hormones. Those can be anti-androgens. Sometimes that can include a medicine called spironolactone, also a very common acne medication. Again, good to know about because that can often have a side effect of dizziness and lightheadedness. And again, of course, for those who do vital signs in their office, you'd want to know if that's the medication that they're on. Is that due to a malnourished state, or is that from their gender affirming hormone? And then estrogen, which again, when we think about what are we thinking about when we take care of our patient population? You can have a decreased systolic blood pressure, decreased lean mass, increased fat mass, sorry for the spelling error there, and increased visceral fat. And it's actually quite fascinating to me when I see patients in our gender clinic, the GEMS clinic, patients literally recite this. I'm looking forward to fat and muscle body changes when I go on gender affirming hormones. So these changes are known and they're out there. So how might this affect weight? I think one great area for future research, especially for those of you who take care of adolescents who are in the process of growing, is what changes can we expect, especially for those who start on puberty blockers or not. There is one meta-analysis that looked at transgender people, again, very binary, that showed very specific changes, the follow-up time average from weeks to just about a year, where you can see that everyone tends to gain weight. The differences being in whether or not it's body fat or lean body mass or muscle. So then again, kind of moving along here, we're going to talk about the eating disorder risk in transgender individuals. When I started work in this area and doing talks in this area a few years ago, there was very little known, mostly in case studies. So if this is one example, this may sound familiar to patients you've taken care of before. Someone 25 years old, assigned male at birth, had a desire for weight loss, and eating disorder behaviors were tied with female gender identity. They found that with weight loss, they appeared more feminine, decreased hair growth, and decreased need to shave, right? So again, like malnourishment to them really was a way to affirm their identity without gender affirming care. Didn't want to gain weight and appear masculine. They actually were admitted to the medical hospital for stabilization. They were started on a form of gender affirming care, again, that anti-androgen medication, so a reversible intervention to lower androgen levels. And to me, a big take home point of this case study, as well as other case studies, and hopefully to you there in the audience, is to consider transgender care and eating disorder care simultaneously. We cannot always disentangle the chicken or the egg here, and there can often be improvement when we treat both together. It's not really a one or the other. And so again, here's another case study, similarly timed. This was a 16-year-old assigned female at birth. This patient had weight loss and admitted to a desire for a different body shape with a more toned and muscular appearance. Again, how often have we heard patients talk about that? And without doing the follow-up questions that Dr. Tishelman introduced, which did not happen at this patient's first visit, there was no exploration of gender identity, right? That sounds like pretty distorted thoughts potentially, but for this individual, they actually had a different gender identity than their sex assigned at birth, which is why they were doing the disordered eating. In follow-up appointment, they said, I dislike my curves, my breasts, my hips, my face. I wish I had more defined muscles in my arms and a more angular face. Again, I think things we've probably all heard before, but without kind of having that second piece about gender identity, it's really hard to put into context. In this person case study, there was improvement of the gender dysphoria and eating pathology. However, again, that doesn't mean that individuals should not be supported from an eating disorder team as well. I really am a big fan of the multidisciplinary approach, which would include an eating disorder team as well as a gender team working together. Again, just to kind of really hit this home, there's just kind of over and over again as we think more broader than case study, epidemiological research are showing increased odds both in adults and in youth for self-reported eating disorder diagnosis, and again, very disturbing weight management behaviors such as past month diet pill use and purging, increased odds of vomiting or laxative use, and this has also been shown in adolescent populations as well. So there was a really good article by Duffy et al. Recently that interviewed, I think it was about 80 folks who identified as transgender or non-binary in eating disorder programs, which really brought up a lot of issues, which I'm sure, again, in your experience, you've probably had some similar things come up. About 15% reported the issue of body image is more complex for transgender clients, which they felt their therapist did not understand. So here's a quote from one of the participants in the study. A trans person may be trying to control unwanted aspects of their body structure with their eating disorder. Trying to assure them that these aspects are okay or normal is not the right answer and only aggravates dysphoria. So again, it can be really challenging in this situation to treat someone with an eating disorder who's also struggling with body dysmorphia. People additionally mentioned in this study that they often felt that if their therapist did bring it up, it was then ignored and not addressed at all, or that they had to hide their gender identity. So for example, assigned female at birth, identify as male, but all eating disorder programs would accept, in their area, would accept women. So then had to hide their gender identity to get treatment for their eating disorder, which was very challenging since they weren't able to be honest and upfront and address their gender identity. So I, again, like this article, there were some really great recommendations that came out for providers, clinicians from the participants. So again, going back to what Dr. Tishelman said, ask, don't assume about gender, always ask pronouns and then use them. I hear stories all the time where, you know, especially for those of us who may document during the visit. I know as a medical doctor, I do a lot of documentation and visit at the same time to survive medical charting, and that patients can see what you're doing. And then I usually ask, what name and pronouns would you like me to use in your medical record, especially since I work with youth and they may not want their parents to know. But if they tell you your name and pronoun and tell you to use it, and then you're documenting using the wrong name and pronoun, patients are savvy, are going to know that, and then you're really, unfortunately, breaking a therapeutic alliance with them. And then again, for those of you especially who work in eating disorder centers or facilities, to really help facilitate access to care for the transgender community. Fortunately, really didn't have time to go into why these disparities exist with transgender individuals having higher rates of disordered eating. We could spend all day talking about it, but a lot of issues with access to care and fear of discrimination from the healthcare system on part of these individuals. And then also clinicians should pursue continuing education in this area. So now we're going to hopefully leave you with some pearls on how to apply some of this information from the first two parts of the talk into your clinical practice. So one thing that, depending on the setting in which you work, that can be easy to change would be to think about adding signs if you already have single stall bathrooms that sort of signify that they're an all gender restroom. And then again, here's an example of a sign that we have at Boston Children's Hospital where we have male and female designated bathrooms, but that folks are open to use the restroom consistent with their gender identity. And then the last picture on the right is our is the shot room that we have in adolescent medicine where folks can get their vaccines. Again, just even putting up a little rainbow flag or a flag of the transgender colors. Again, it can be small, it can be free to put up there, or very, very low cost, and folks for which that matters are really going to notice that that's there. We all wear lanyards that are rainbow, again, to signify that we're affirming clinicians, which can make a really big difference. And then also I think a lot about, you know, from the start, I introduce myself with my name and pronouns. It's very easy to do, doesn't take a lot of time. If we were working together in person, I'd have you turn to someone sitting next to you and actually practice, which you can, you know, bring this home to the folks that you work with where you are to really practice introducing yourself with pronouns. When I'm in the gender clinic, I do this in front of everyone right away. When I'm in my adolescent medicine, wearing my adolescent medicine hat where I'm seeing patients with anorexia or doing primary care, I often do this in the confidential portion with my adolescent patients because they may not feel comfortable in front of their parents then saying, oh, my pronouns are they, them, theirs, for example. Again, what are some unique challenges? You probably know them, which is why you're interested in hearing more about this information. I mentioned already what growth chart to use can be really challenging, especially those of you who work with adolescents, and the fact that gender-affirming hormones lead to muscle and fat changes. For those individuals where that's not desired, again, the very severe anorexia, for example, and kind of have read online that estrogen is going to lead to increased body fat, that can be very challenging. The use of binders or packing by patients, which I'll talk about. Weights in a gown can also be really traumatizing as well. I typically recommend, depending on the patient, I want them to come back. So when I'm doing my blinded weights for patients in a gown, I talk with them about potentially leaving their binder on, which I'll talk more in a moment. And if they're having large weight fluctuations, then we revisit it because the goal, right, is for them to stay engaged in care. And then of course, the use of medicines that can cause menstrual suppression. So one clinical pearl is there was a study that came out recently that showed increased prevalence of non-suicidal self-injury or cutting and suicidal ideation in transgender people with eating disorders. We already know that people with eating disorders are at increased risk for these behaviors and thoughts, but even if you take a look at kind of all individuals, transgender individuals with eating disorders have the highest risk. So my recommendation was clinicians should regularly assess this risk in their patients by asking and that for those of you who are medical clinicians who do a physical exam, do not forget a good skin exam, right? These patients may be wearing baggy or large clothing in which to hide their body shape for many reasons, whether it's gender dysphoria or because of body image related to an eating disorder. And you definitely don't want to miss signs of non-suicidal self-injury. So for those who are not familiar with binding, so this image is a kind of an example. It's like a compression style top that an individual can wear that's used to make their chest have a more masculine appearing underneath clothing and help them pass. And this again, right, this obviously has weight to it. Of course, there's a possibility that someone could manipulate their weight by putting something in the binder, right? I've had patients who had quarters and jock straps or in their hair and things like that. But again, I think it's really important to build alliance with patients and then kind of talk about it. We set the expectation. If you have really large fluctuations in your weight, we might have to revisit this policy. And then I usually document in my note whether or not they're wearing a binder for their weight. In my clinic, we also have patients leave a urine sample before their weight. So it's a quote unquote dry weight. I have patients who are incredibly dysphoric about their genitalia, in which case leaving a urine sample in a doctor's office can bring them to tears, or we can't get them to go into the bathroom or come out of the bathroom. It's so distressing. So again, I document that and really try to think about other signs of malnutrition that they may have on their exam. Do they have lanugo? What is their blood pressure like? Are they fatigued? Are they having orthostatic vital signs? Rather than really relying just on that weight number as the only indication of how malnourished they might be. Something that I myself learned about in the past year or so is really thinking more about body neutrality instead of body positivity. I think body positivity for many individuals is a wonderful goal, but for those who are transgender and may not identify with their anatomy, to say that they need to be body positive about a body they do not identify with is very invalidating and doesn't work. So we think more about really like a harm reduction goal. So focus on function. I really like this quote from the folks at Seattle Children's in their gender clinic: respect your body enough to fuel it and to not do harm to it. So for example, patients often cannot be underweight in order to have a gender affirming surgery. So that can be a great goal for them. They need to stay out of an eating disorder program to participate in Course Rate Alliance activities at school, or to go to camp, or to be in theater, etc. So again, thinking a little bit differently, which I know that can be a real frame shift for those of us who take care of patients with eating disorders, moving away from body positivity. But again, I think in the long run for this patient population, again, highlights why it's so important to assess gender identity in our patients. And then thinking about higher levels of care, right? This recently happened to a patient of mine, assigned female at birth, has already had a masculinizing top surgery, so a mastectomy, is on testosterone, really needed more help with his eating disorder, but was very, very nervous about going to a program because eating disorder programs are for girls, is what he told me. He's like, and I'm not a girl. So this is a really great opportunity to advocate on behalf of your patients. So reaching out to programs, if you don't work at a program yourself, is the program gender segregated? Is it by gender identity? What about your non-binary patients that you take care of? And what is their experience with taking care of transgender or non-binary patients? Are they open to teaching, as in receiving some learning about this topic area? Can you give a talk or set expectations? I've heard some horror stories where patients are not allowed to stay on gender affirming hormones and eating disorder care treatment, which is very unfortunate. You can imagine how challenging it would be to treat someone who's not feeling like their identity is being affirmed. And so again, kind of explaining or potentially educating why it's important for someone to stay on a medication like testosterone or estrogen, etc. And then what other supports do they offer? Is it support for the family? Is it just for the individual? Again, this might vary based on the level of care and whether or not you're taking care of an adult or a minor. So again, for those of you who take care of adolescents, this question comes up a lot: which growth chart to use? Again, not a lot of research, basically none in this area. I hope that we will have more in the future. Just as I would say, it depends on your electronic medical record or EMR. The institution where the three of us work, we're actually able to change the growth chart from male to female. And so I would say if someone is on gender affirming treatment, you should go with that hormones kind of assigned at sex, birth, growth chart. So for example, someone's assigned female at birth, they're on testosterone, I'd use the male growth chart, but and you can also plot by hand the old-fashioned way on a BMI curve. However, to me, what's more important, even with my cisgender patients who have anorexia, is I look at the overall trend, right? It's more than just getting to the 50th percentile, depending on where they've grown before. So again, looking at their overall trend and thinking about that as goals, knowing in the back of your mind, these patients tend to gain weight when they're on gender-affirming care. So it's especially alarming if people are losing a lot of weight once they've started gender-affirming hormones. And of course, as I mentioned earlier, monitoring other signs of malnutrition. And hopefully we'll have more information on this in the future. So to sort of finish up, how to screen for eating disorders in this population. This can be really challenging since a lot of our existing eating disorder screens that we may use have a lot of questions that could be related to gender dysphoria, like I feel dissatisfied with my body. That's going to be positive for someone who's transgender or non-binary. So some other options, again, some tips from Seattle Children's. I'm happy with my eating habits and weight. In the past year, I've tried to lose weight or control my weight by vomiting, taking diet pills, or starving myself. How have you felt about your body or shape in the past in general? And what do you like or not like about your body? And what would you like your body to change to match your gender identity? Again, it'll be hard to know how to interpret some questions if we don't ask the gender identity up front in a confidential way. So just some very quick take-home messages. Ask your patients and clients about gender identity, and then continue to assess over time, especially for those of you who work with children and adolescents. Considering partnerships with gender clinic in your area, and continue to educate yourself on gender, and that currently there's not evidence to support delaying gender-affirming treatment in order to treat an eating disorder, and consider treating together in a multidisciplinary team. And then some resources for you. Thank you.
So we know that was a lot of information, but thank you, Dr. Gus and Dr. Tishelman. We have left a lot of time for questions, so we will start the question and answer portion of the webinar now. So you can type it into your box and we will read the question and then the doctor will answer. And if we don't end up receiving any questions, we usually will have the moderator ask a few questions that would be relevant, or we will expand upon some of the topic areas that we feel need more time. So if people can just send their questions in right now, that would be very helpful. Yep. So unless we're doing something incorrectly, we don't see any questions. Okay, so Dr. Gus or Dr. Tishelman, do you have any areas that you feel like you would like to expand upon that is important for somebody who is working with a patient with an eating disorder and they may not have the resources that we have at Boston Children's Hospital?
I would just say that some of the issues I wasn't able to talk about were some of the other clinical complexities of working with transgender patients. They're, aside from the importance of understanding their body image and attempts to control their body and eating disorders, there are many other complexities about working with this population in adolescence. Sometimes, as we alluded to, there's suicidality and self-harm, which really needs to be screened for in every patient as well. So there are patients, what Dr. Gus was saying about not putting off gender-affirming care because of the eating disorder, sometimes they're linked, but also sometimes putting off gender-affirming care could contribute to self-harm and suicidality. Oh, good. I will change direction for a minute because I see a question about this slide on the controversy of social transition in children. I would like to, I think it's a very good question because I was going pretty fast. So I did talk about some of the controversies about social transition in young children, but also the research that shows that in fact, it seems to be very helpful for many children to socially transition. So I'm working right now on developing standards of care for kids, but one of the critical factors for mental health seems to be support and affirmation for children and social transition for kids who really are unhappy being perceived as the wrong gender without a social transition seems, with the data that we have, like it can be really protective. And we don't have data right now to suggest that detransitioning for kids who maybe are fluid or later on start to think about their gender in a different way. We don't have any data to suggest that detransitioning is harmful to kids. There's a little data from a long time ago on 2 children in Europe who were unhappy in detransition, but both social transition and detransition are likely affected by environmental factors. And so if kids are supported in living in whatever gender they feel comfortable at any given time, then what we're calling a detransition may just be an evolution in a gender journey. And it probably, and this is just speculative, will be okay for kids to do that as long as they're supported in whatever gender identity they affirm at a given time. So I wanted to explore the controversies because there are a lot of strong feelings in both directions, but I definitely do not want to recommend that children should not be allowed to socially transition if it's perceived that it would help them.
So the next question is, can you speak to any cognitive or mental health changes to factor in when introducing gender-affirming hormone intervention?
Do you want to take it or do you want me to take it?
I think I'm not completely
like
sure.
Depression or anxiety.
Yeah, I whizzed through those slides because I got a note that I was running out of time. There's a paucity of data on this. The data that we have mostly emerges from Europe, where they were way ahead of the United States in initiating gender-affirming medical care. So the first clinic was in Amsterdam, and the research comes from there mostly. New research is starting to come out here in the United States, and we at our institution are part of a consortium of four medical centers: Boston Children's Hospital, UCSF, Children's LA, and the core center is Children's LA, and Lurie Northwestern Children's Hospital, where we are prospectively studying youth who get puberty blockers and cross-sex hormones to understand both medical and mental health outcomes. A study did just come out to show that suicidality decreased in youth in the United States after receiving puberty blockers. And the research from Europe shows that children who received puberty blockers and then went on to receive gender-affirming hormonal treatment and gender-affirming surgeries had many of their mental health morbidities remit and were doing much better. And I will let Dr. Gus answer.
Okay, so we have a question. Somebody would like to know about what we know about the chronology and timeline of the co-occurrence between disordered eating and gender identity concerns.
I think that's a really great question. I think unfortunately we don't have the research or information to know, especially on like a population level, what that timeline looks like. Again, this is really an area where there's a really large paucity of research. So I think it's hard to know. I think unfortunately there's not an answer yet that we know.
Unfortunately, we don't have as much research as I wish we did to help kids, because people use the lack of research as a way to fuel controversies. And I'd just like to share that somebody is mentioning that right now there are, both in Europe and in the United States, movements to ban care for transgender youth and medical intervention. And everybody I know who works with transgender youth is very worried about the impact of this. I'm worried even about the impact of the uncertainty of people fighting against the care for the youth that we see. It's frightening. For some children and adolescents, anecdotally, can be life-saving to get interventions. And I want to stress again that there is high suicidality. Sometimes there's a lot of anxiety about this in families, or family rejection that can be very painful for kids, or a lot of family discord. All these factors need to be assessed for, because the eating disorder can emerge in the context of a lot of conflict within a family, or bullying, or peer rejection, and uncertainty about sexuality. So I think it's important to understand the whole person and the context in which they're experiencing these issues.
So another question is, what resources do we recommend to the family?
So if these are resources meant for transgender youth, I really like Gender Spectrum is one option. And then as far as support for parents, I like to recommend PFLAG. So P is in Paul, FLAG, which is an organization that helps support families. Dr. Tishelman, I don't know if you have others that you like to recommend.
Oh, I want to reiterate, in case you didn't catch it, Gender Spectrum is an excellent website with a lot of information, both about medical interventions, but about working with schools and the importance of family support. So I recommend that website often for my families. There are also some really good books out there for families on living with, or for professionals treating adolescents and working with them therapeutically. I'm trying to remember. I'm actually having a blip where I can't remember the name of my favorite workbook, but there are some really good resources for people that I suggest they read. Another resource is Diane Aronsoft's book, The Gender Creative Child, or Gender Born, Gender Made, which are really good introductions, I think, into gender diverse children.
And then I'll also add that the Pediatric Endocrine Society has really nice summary handouts that are meant for patients and families that cover, there's different handouts. If you Google Pediatric Endocrine Society handouts, there's a whole section on transgender health. There's one on support for parents, supporting your gender diverse child. There's one on masculinizing treatment, one on feminizing treatment, one on school support, and one on puberty blockers. So they're about 1 page each, written in very easy to understand language that can be really helpful for families as well.
And for those of you who might be psychologists, the American Psychological Association website has information about gender diversity and transgender youth, and they had a task force that wrote a report on gender variance. It's a little old now, actually, but I think it's still valuable. I also think WPATH, the World Professional Association of Transgender Health, is a good resource and a good website to look at. And then there are conferences that families can be directed to. For instance, in Philadelphia, they have a conference every year for families and professionals on gender diversity. And a lot of my families have gone and felt like that was a great experience for them. In California, UCSF has an annual conference for families as well. And I think attending them, not feeling alone, I think is really important for kids. So sometimes joining groups can be helpful. Finding the resources in each community for families can be very important. At schools for kids, joining like GSA groups for kids can give them a home, gender and sexual diversity groups. So I think helping kids find what they need is important. I will say this, some of the youth that I've worked with don't like to associate themselves, or don't like to think of themselves as transgender. There are some kids who would like to, will say, I don't want to go to transgender groups, I'm just a boy. So somebody who is assigned a girl at birth may feel like, I just want to be perceived as a boy, not as a transgender boy, and I just want to be a regular kid. So I have come across that, but a lot of other youth don't feel like that.
Okay, so thank you, everybody. That about wraps it up. Thank you again to Dr. Gus and Dr. Tishelman for a fantastic presentation. Just a reminder, you can find out more about our presentation and other upcoming webinars on the AED website by visiting aedweb.org and clicking on the events tab. Our presentation will be posted, and thank you so much, and have a great day, everyone. Thank you.
Thank you.
Bye.
Bye.